Hello, everyone, and Happy New Year. The Coordinating Center for the National Drug Early Warning System, sponsored by the National Institute on Drug Abuse, welcomes you to our first NDEWS Presents webinar of 2018. The NDEWS PI is Dr. Eric Wish, and our NIDA project scientist is Moira O'Brien. I believe that both of them are in the audience with us this afternoon. My name is Erin Artigiani, the NDEWS co-investigator. Barbara Kerr, Marwa Al-Nasir, and I will be the facilitators for this webinar. We are all part of the NDEWS Coordinating Center team. For those who are interested, you can find detailed information about NDEWS, recordings of prior webinars, and invitations to future webinars on our website at www.ndews.org. You will also find instructions for how to join our NDEWS network and participate in ongoing discussions with more than 1,700 experts and concerned citizens from across the United States and many other countries. We developed the NDEWS Presents webinars to work with leading substance abuse experts to explore emerging drugs and timely drug-related topics. This month, we are highlighting the efforts of the President's Commission on Combating Drug Addiction and the Opioid Crisis. This afternoon, we are very excited and fortunate to be joined by Dr. Bertha Madras, a member of the Commission and a professor of psychobiology at the Harvard Medical School. She is currently based at McLean Hospital. This webinar will be approximately 60 minutes long, but may run a little longer depending on the number of questions and comments received. We encourage you to submit questions during and after the presentation. Please post your questions in the Q&A box. Don't raise your hand, use the box and submit your questions in writing. We will hold a brief Q&A session after the presentation where I'll read the questions aloud for Dr. Madras to respond to. She will do her best to get to all of your questions, and we will try to address any remaining questions after the webinar. A recording of this webinar and a copy of Dr. Madras' slides will be made available on our website, www.ndews.org, a few days after this webinar. Thanks again for joining us, and we hope you enjoy this NDEWS Presents webinar.
Thank you very much, everyone, for joining me in this important session, and thank you, NDEWS and Eleanor and all the staff for making this possible. I am going to try to run through as much information as I can in the period of time, beginning with my disclosures, which represent either non-financial or financial affiliations that I've had recently. We are all aware, people who have expertise in drug addiction and drug use, that this crisis has affected every single sector of our society. And I'd like to begin just with a very brief introduction. The ancient Greeks had an interesting terminology, pharmakon, which referred to both a pill and a medicine. And there is no greater application of this generic word than as it applies to opioids, because opioids can have remarkable medicinal properties. They can reduce pain, they can reduce gastrointestinal excess motility, they can affect sleep, they can induce sleep, they can provide a level of serenity on the same and on the same hand, they also are highly addictive. And this dichotomy in their pharmacological properties is what we are concerned about today. Pain is the #1 drug for using drugs with abuse potential. And one of the problems is that pain and pleasure centers in the brain are closely linked. What I'm going to present today is a brief overview of the state of the crisis, some of the root causes, the reason for indulging in the root causes so systematically is that one of the concepts I had for the commission was to understand the root causes and see whether or not some of these, in fact, all of these could be reverse engineered as part of the recommendations for the report. The reverse engineering is among some of the many goals that we have in the commission. Obviously, reverse engineering is not going to cover all the current needs that have emerged over the past 15 years. Then I will summarize the recommendations and finally close with lessons learned. The United States, and I thank Keith Humphreys for this, leads the world, leads the 30 nations with the highest opioid prescribing in terms of standard daily opioid doses. We are so far ahead of most other countries. In fact, if you average out the standard daily doses, we administer 5 times the number of prescriptions compared to the average of the highest prescribers. And that puts us as the number 1 nation in prescribing. We also happen to have the dubious distinction of being the number 1 nation in terms of overdose deaths. This is little Estonia, and they managed to solve their problem by cutting down the deaths within a couple of years. So there are no other countries that are approaching us in terms of overdose deaths that I'm aware of. The overdose deaths have escalated rapidly over the past 15 years, but it is a shifting scene. All drugs in 2016, the overdose deaths were about 64,000. One of the major contributors were prescription opioids, but that number is declining. Heroin is still increasing, but definitely the lion's share of the overdose deaths now is attributable to fentanyl. So any type of approach to solving the problem has to take into account that although the catalyst was prescription opioids, we have to consider as well the illicit production, marketing, distribution of fentanyl and heroin, which appears to now subsume the overdose deaths due to prescription opioids. To such an extent, to such a disastrous level of death, that first responders now include firemen, policemen, librarians across the country. And we also have to remember that 20,000 of the deaths in 2016 were unrelated to opioids. And bearing that in mind, we need to consider the fact that this is a substance abuse problem in general. Opioids are clearly a very dangerous class of drugs because of their capacity to depress respiration and kill people very rapidly, especially very potent drugs like fentanyl. But that other drugs such as cocaine, methamphetamine also account for some of the 20,000 that were registered in 2016. We've seen more than a 3-fold increase in opioid use disorder. The driving force originated with prescription opioids, and now there is a transition and/or an initiation with heroin and fentanyl. The root causes are critical, as I said, because some of these root causes, if they could be reversed, would be instrumental in helping us reduce the number of deaths as well as the addiction rate. So let's begin with some of these root causes quickly. There is and was a systemic medical education void. Generational forgetting. Those of you who were not born in the 19th century, and I don't think anybody on this webcast was, we had a massive iatrogenic opioid addiction problem during the 19th century, which involved the misuse of morphine and opium, largely in populations of females and also the Civil War veterans as well as soldiers who were administered morphine by the intravenous route. And what we didn't realize at the present time is that opioids are highly addictive drugs. And the generational forgetting was in principle critical problem in medical school education. In 1875, there is a report of an individual lamenting the iatrogenic opioid addiction problem in the country, saying, why can't we train medical students to understand what a significant contributor this class of drugs are to death, and we must, above all, train them to administer them very judiciously. So we switch from opiophobia to opiophilia, and some of the factors will come into play very quickly. Quality science was ignored. Pain management and opioid prescribing was not a core component of curricula in medical schools in the United States. And another problem was that addiction training was essentially disconnected from healthcare training and education. And this disconnection, which was prominent, led to the emergence of rehabilitation centers, which were largely not integrated with the healthcare system. These were the medical education voids. For decades, prescription opioids were avoided for chronic pain because of fear of addiction, overdose, and ineffectiveness given in the long term. In 1980, a letter to the editor of the New England Journal of Medicine by Porter and Jick, titled "Addiction is Rare in Patients Treated with Narcotics," excavated the incidence of addiction in hospitalized patients. And let's not delve into this too deeply, except for the conclusion. Despite widespread use of narcotic drugs in hospitals, the development of addiction is rare in medical patients with no history. The evidence was quite weak for claims of non-addiction because in hospitalized patients, they may be administered opioids for very short term, for very discrete acute pain. And once they are released from the hospital, they may never see these opioids again. What was the problem with this letter? How many doses? For how long were the patients given the opioids? Did they have chronic pain? Was there safe use outside of the hospital? How is addiction assessed? What were the long-term outcomes? None of these issues were addressed. But what happened in the literature is that this 5-sentence letter to the editor started to be cited very dramatically, starting in 1981 and 82, just a couple of years after its publication, and continued almost exponentially, not quite, until 2017. The blue bars, the dark blue bars, show that all these references to that letter were affirmational. That means that people agreed that narcotic opioids are not addictive. And only in 2017 did we see all the references to this letter in negative terms. This was an astonishing development because this letter garnered 600 citations. Most letters to the editor don't garner more than 10. It clearly had an influence in the field. So low quality science, and it really was low quality, especially the conclusions and the headlines, received affirmation for decades. And a movement began. A movement began to shift the blame to the provider. If patients have pain, it has to be treated aggressively. A patient movement began. Initially, it was a movement by a few physicians. Then it moved into the patients. Then the pharmaceutical industry showered the field with a vast amount of money to educate patients, clinicians, pain societies, and many other professional associations on the non-addictive properties, especially of long-acting opioids. And the rationale for for convincing the FDA and the rationale for indicating that opioids, especially long-acting, were not addictive given to pain patients for chronic use, was based on pharmacokinetic properties of the opioids, because the extended release ones had slow onset pharmacokinetics. And this was taken as a measure of the lower abuse liability of these drugs. The Veterans Administration then adopted pain as the fifth vital sign and mandated pain evaluation and mandated treatment. The Joint Commission and others also adopted pain as a fifth vital sign with assessment of pain, treating pain, patient satisfaction, and accreditation being based on these criteria. So the pressure on physicians for addressing pain with opioids began to increase. And very soon these little charts came into doctors' offices, hospitals, asking patients specifically, what level of pain are you experiencing, regardless of the reasons why they showed up in hospitals. And soon we began to see a vast increase in prescribing opioids. The healthcare community was subject to a lot of pressure, including, as I said, inadequate medical education. Patients were not given informed consent on what these opioids could or could not do. There was very little patient education. Pain as the fifth vital sign became de rigueur. There were barriers, insurance barriers, to medications-assisted treatment and to addiction treatment, but there were no barriers to prescribing of opioids. There were no guidelines to prescribing in terms of what types of pain, what number of doses, the dose ranges, and so on. There were financial incentives to prescribe opioids through value-based purchasing from the Centers for Medicaid and Medicare Services, through pain surveys, through Press-Ganey scores that evaluated hospital based on patient satisfaction. The FDA was languid during this period, and as prescription opioids tightened, as there was a movement away from extended release formulations into abuse deterrent formulations, there was no contingency in place to treat substance use disorders. And I have, at this point, and I certainly do not have the time to go through them, but at this point I would conclude that there are at least 30 factors that fed into this opioid crisis. Some of them I've already alluded to and described in terms of flawed safety claims that opioids are not addiction if given chronically, especially with the appropriate pharmacokinetic properties. There was aggressive pushing of opioids by the pharmaceutical industry. The FDA's safety and efficacy stringent criteria for drug approval did not take into account the possibility of drug diversion, of escalating doses by individuals, of excess doses for conditions such as a dental extraction, where patients were prescribed anywhere from 30 to 90 opioids for a simple dental extraction, the pain of which may last only a day or two. There was no consideration of all these extenuating circumstances in terms of safety and efficacy. Pain societies joined on the bandwagon. I'm not going to list them. NGOs did, JCO, which is now the Joint Commission, the VA. There was media advocacy, poor medical education, poor patient education, rogue pharmacies, rogue physicians. The Federation of State Medical Boards gave a pass to physicians who were prescribing opioids for long-term. Insurance companies, as I said, were working in the opposite direction. Prescription opioids were approved without question. Medications-assisted treatment and addiction treatment had to have pre-approval hurdles to go through. And some of these others I have already alluded to. SBIRT, which could have helped physicians understand the substance use history and status of their patients, the reimbursement levels were very low. prescription opioids were tightened and or made abuse a deterrent without foresight as to what the consequences could be for those who became addicted iatrogenically to them. There were inadequate treatment slots, inadequate rescue with naloxone, inadequate prevention. There was a firewall between addiction treatment and medical treatment, so the medical community was not integrated with the substance use disorder history and issues of their patients. The guidance did not exist on prescription opioids, how many doses, for what medical condition, for how long. And it's possible that shortened hospital stays where patients were released with a large prescription of opioids may have also led to this. Here's an example of NGOs. The Open Society Institute issued a brochure saying that patients in pain are casualties of the war on drugs, which was a political stance. And so currently we have about 12 million misusers of opioids, approximately 2 million people with an opioid use disorder, 600,000 with a heroin use disorder. I am 100% convinced these are underestimates in terms of the magnitude of the problem. And in the meanwhile, the country became awash with opioids. How do people become addicted who are prescribed opioids? Some of them have inadequate pain control. This is a single study. We need many more studies. This is by Connie Wiesner's group at Kaiser Permanente, which came out last year. They have inadequate pain control, and so they start to escalate doses until the dose escalation becomes out of control. There are some patients who self-report likability on initial exposure for pain relief. Or others, and this is the majority of all of those, this is the number one reason, is that they initially used for psychoactive purposes. There's a cohort that reported relief from emotional stress, the use of opioids for that person until they began to escalate and use more and more frequently. And others had a prior substance use disorder, yet also have pain. But once they were prescribed opioids, and if they had a heroin use disorder prior, the opioids would trigger, obviously by cue-related mechanisms, a relapse. We now know that the portions of people entering treatment that initiated with prescription opioids has declined very dramatically, from 90% over a decade ago to 67% more in more recent data, which implies that people are initiating opioids using heroin and fentanyl as opposed to prescription opioids at a higher rate. That does not mean that the prescription opioids are, in fact, that problem has waned. There still is a two-pronged problem here based on the two different classes of opioids. So what happened at the same time in the 1980s, the purity of heroin began to increase, the street purity, and the price of heroin began to decline. And with the introduction of fentanyl, the emergence of fentanyl, which has 50 times the potency of heroin, there was tremendous economic incentives from producers, from marketers of the illicit trade, economic incentives to mix fentanyl with heroin because the volumes would be smaller, the drug is more potent, the costs are low, the transportation is easy, they can be mailed in envelopes because of the high potency, and also because drones can fly over opium fields, opium poppy fields, and spot them. But the chemistry, the chemical synthesis of fentanyl, which is essentially a meperidine or Demerol derivative, it can be covert and can be hidden in chemical labs without visual oversight. Many heroin users don't seek fentanyl. and it's hard to identify. And the folks who don't seek it but get it inadvertently, either as a mixture with heroin or in pills that are disguised as prescription opioids or mixed in with other drugs such as cocaine, they are being flummoxed and are at life-threatening risk in using these drugs because of it. Some of you may or may not remember that we had a fentanyl crisis in 2006, 2007. In terms of DEA seizures, fentanyl spiked. We had close to 1,000 deaths of fentanyl in that period. And the elimination of labs that produce the fentanyl just made that problem disappear almost overnight. The death rates declined to baseline, and fentanyl was gone. And now we see this massive upsurge in fentanyl again. The producers are different. In this period, it was a super lab in Mexico, a few labs in California, but currently the lion's share of it is coming from Chinese labs, and transportation is via Mexico. So it is clear that we entered a period which I call a perfect storm, where heroin prices, fentanyl availability increased as prescription opioids were considered more and more hazardous. And now we transition to the Opioid Commission. The commission was sworn in June 16th of 2017. The commissioners included 3 governors: Governor Christie, who chaired the commission, Charlie Baker, Roy Cooper from North Carolina, Congressman Patrick Kennedy, who you know is a ferocious advocate for mental health and substance abuse parity laws and adherence to them. There was myself and Attorney General Pam Bondi. Each one of these individuals, the governors, the congressmen, the attorney general, had been very heavily involved in their states in trying to alleviate the opioid crisis with views. The commission met 5 times. In between those 5 times, there was a very massive amount of work. There was a website that was open for comments. By July 7th of 2017, I had written over 250 headings that I felt could be included in the report. And Governor Christie felt that if we made a report with 250 headings and possibly 300 to 400 pages of text and recommendations, it would be yet another electronic document that gathers dust in federal government servers. And of course, he was correct. So what were the commission's tasks? What is the federal funding for addiction? What is the availability of treatment and overdose rescue, primarily naloxone? What is the current prevention in terms of education, prescribing practices, and the prescription drug monitoring programs? How effective are educational messages for prevention? And what are the current status of federal prevention treatment programs and recommendations to improve the federal response to the president? And when I looked at this, there are many systematic analysis of the opioids. There's some wonderful health economists who have been involved in this, and some of them have tried to develop a systems approach to it. I looked at it more as how do we begin and what is the end point, which is the supply, the risk factors, initiation, escalation, overdose, opioid use disorder, the withdrawal, including relapse and rescue, treatment quality, the abstinence period, how we can increase that period, recovery, and lifelong abstinence, taking into account the impact of the crisis on children, on families, on prisoners, on health, on safety, on costs, and on productivity. So that was the framework. And what the commission report, essentially the components were, the first set of recommendations were accountability. If the federal government issues money for the crisis, how are we going to account for it? What metrics will be used to show that the money has been well spent, it has been spent judiciously, and in high impact areas, in people with most in need, and can have the greatest effect on the crisis. Other components were prevention, treatment, rescue, recovery, research, and also who would do it. And what is very clear from the final report, which has 56 recommendations plus 9 interim ones, is that everyone in the United States, everyone has to be a part of the solution. This is not only a federal government issue, it's not only state, it's not only local, it's not only community, it's education at the level of parents, of their children, of schools, of every sector of society. We all have to step forward and cooperate in this. So of these recommendations, federal funding, how to streamline funding, how to track, and accountability. And one of the most frequently heard requests from state governors was, let's just put everything into one block grant instead of these little mini grants that require different reporting, different types of proposals, different types of accountability. It is so much easier to streamline the funding for tracking and for accountability. Prevention would be for individuals, for youth, and through national media. Prevention would imply also supply reduction. Prevention would imply a medical prevention, which includes physician and patient education, alternatives to opioids, the prescription drug monitoring component, and how to deal with pain. The data analytics, I felt, was one of the most important things to propose, and in the course of the commission period, I spoke with a number of very advanced technology companies that are experts in data analytics, and asked them whether or not there was ways of obtaining data in real time that would help us focus and target responses in the areas with greatest need. We looked at the barriers to treatment. Some of the greatest barriers are quality of treatment. The data that I excavated in 2012 on how many treatment centers, there are 14,000 in the country, how many of them offer medications-assisted treatment? That number was less than 30%. What are the barriers in terms of insurance company coverage? What are the barriers in terms of treatment slots? What are the barriers in terms of staffing, in terms of access to medications-assisted treatment? What are the barriers to the convicted who have a very high risk of overdosing if they had a heroin use disorder or an opioid use disorder prior to incarceration? They lose the tolerance during prison, they come out, and they can succumb to an average dose of opioids because they're no longer tolerant. So there are many barriers in terms of quality. Barrier is one of the most important ones that I feel has to be improved greatly, as well as insurance. And only with increasing quality in insurance company coverage do I feel that treatment slots will open up to provide high quality treatment. There are barriers to rescue. The distribution of naloxone is uneven in the country. There is a concern of being arrested if on site with regard to calling in an overdose. and also the issue of warm handoffs. That means handoffs to people who have been rescued. Do we just let them walk up, stand up, walk away without any intervention, without any effort to motivate them towards treatment, or to begin to initiate medications to make them realize that one can feel relatively positive and normal under the influence of medications and not have some of the behavioral problems associated with continuous repeated use of the drugs that they have become addicted to. Recovery support systems and services for families, for children, for colleges, housing, employment, all of these we considered, and very significantly as well medications. New medications for pain management, new medications for treatment, new medications for overdose, because fentanyl is so potent that there are some reports in the literature of requiring multiple repeat doses. And is there an option to fentanyl? And also, is there an option to naloxone that could be more effective in reversing fentanyl, high potency, high affinity opioid agonists for the mu opioid receptor? The other issue is, how can we reverse an overdose and yet maintain the person without them going into a frank withdrawal that can be not only dangerous in terms of vomiting and aspiration, but also in terms of feeling so miserably sick that they simply crave the next opioid agonist dose. And also medical devices that can monitor anoxia, ischemia, and so on, and can be used to alert responders that someone is going into an overdose without anybody else present. As an example of the rationale behind this, in New Hampshire, people have died. 75% of the overdose deaths are related to an overdose alone, without anybody even being aware or having the capacity or facility to respond, because the individual is alone. So these devices may be, in fact, useful for those individuals. The media campaign that we proposed is not the traditional campaigns that people conceive of. They would take into account modern social media, modern social networking that was not available at the time, that television was really the only source for mass campaigning. School-based screening, brief intervention, and referral to treatment. What John Knight and his cohort in Boston have shown is that youth in high school situations are more likely to respond to an electronic device that asks questions about their substance use, rather than face-to-face, where some of them may feel shy, embarrassed, unwilling to talk openly. So there can be devices that are used to screen young people for this. The next solution is clearly how to get rid of all the constraints that pressured physicians to prescribe opioids. And many of these were addressed in the commission, so that we we made recommendations to unleash the physician from the type of constraints, including asking for pain, evaluating patient satisfaction based on pain, to help them administer good medical practice without feeling pressured to prescribe opioids, which is certainly prevailed for at least a decade. The prescription drug monitoring program, which enables physicians to examine the status, the prescribing history of patients, had a number of weaknesses that we recommended to try to improve, and I'll try to show you why the rationale is for some of these. To increase electronic prescribing, to mandate checks on this database, to integrate the electronic health record with substance use disorders and overdoses, to improve the state integration, and also to improve what the printout looks like. We know that there are different practices that prescribe different levels of opioids. Family practice is number one, internal medicine number two, and so on and so forth, in terms of the percent of total opioid prescriptions. But in terms of the percent of prescription opioids compared to total prescriptions, it is clear that pain medicine, surgery, dentistry, physical medicine and rehabilitation, emergency room docs are the ones that have the highest prescribing rates in terms of total prescriptions. We're seeing changes in terms of decline among surgeons, amongst dentists and emergency medicine prescribing, but there are increases in some of the others. And what we find is that in terms of prescribing, we really still maintain a problem in terms of the discrepancies in the country. In some areas, the prescribing of opioids is 6 times higher than in other counties, not countries. The prescribing is much higher amongst non-Hispanic whites with prevalence of diabetes and arthritis that are unemployed, that are enrolled in medication. And this shows you the county by county discrepancies across the U.S. That's the CDC data. This is another set of data that showed that 90% of patients who overdose continue to receive opioids, prescribed opioids by their physicians, and 63% continue to get high doses. One of the problems is that there's no reporting requirements for people who overdose from emergency departments or first responders to report back to the primary care physician. And this is one loophole that we try to address in the recommendations. Training and regulations to reduce supply. I'm not going to just read these things. You'll be able to access them through the slides. To improve the CDC guidelines, to develop a national curriculum, mandate training for opioid prescribing and pharmacy training, to develop model training for screening for substance use disorders and mental health problems. That's critical. And eliminate the pain survey questions and incentivize alternatives to opioids. As I alluded to before, big data analytics is a critical piece as well. And we looked at all the components that could benefit from big data analytics in terms of real-time overdoses and deaths, in terms of prevention, attitudes, and messaging. Where are medications available? Where are the gaps? Where are the gaps in treatment slots, insurance company gaps in compliance? We also developed recommendations to improve treatment, which is so critical. Reimburse for true costs, comply with parity laws, recovery coach training, quality recovery residences, quality outcome measures, quality standards. We also developed methods to expand access to treatment and quality treatment. And this implied using quality measures so that patients would be screened for substance use disorders, physicians would be trained in addiction, increase the capacity, increase quality, treatment referrals, medication, use telemedicine in underserved areas, and provide recovery support services. The next thing that we wanted in the next topic category was to improve the government response. And these are many areas: expand the Good Samaritan laws, fill the Narcan rescue gaps, the reporting gaps, the treatment gaps, help families, pregnant women, and children, reduce the supply at all sources, increase medications-assisted treatment in criminal justice, and more federal drug courts. I have left out a great deal of reducing supply, but this, as you can see from the fentanyl history in 2006, being able to interdict the fentanyl and heroin supply can create an enormous dent in the problem if it's done wisely and judiciously. The patient has the right to know and the right to refuse opioids. There are many other categories here. A patient should recognize a red flag if they're given prescription opioids and they don't necessarily need them. Research, as I alluded to earlier, there's a crying need for alternatives to opioids, improved medications to treat opioid use disorder, improved rescue drugs, improved devices, and a fast-track approval. Finally, I'd like to conclude with two thoughts. One is the lessons learned from this. The lessons are critical for us to prevent future crises such as we have, to educate every component, every domain that was involved in promoting this crisis. What are some of these lessons? To scrutinize evidence for quality. Any trained scientist could have looked at that letter to the editor, to the New England Journal, and said, this should not be accepted. It is too hazardous because it does not offer the most important criteria for the conclusions that were drawn so facilely. We have to scrutinize marketing data for accuracy or suppression of evidence. You know, to claim that opioids are non-addictive, to claim that, for example, currently that marijuana is non-addictive is a problem. To engage not all the stakeholders involved. There was no outcry from the medical community that we need to prescribe more opioids at the beginning. There were a few very forceful advocates among physicians, but they were a minority. Most physicians felt that the way things were going with opioids was just about right. Yes, you could treat patients with opioids for a non-acute care, for non-post-surgical care, for non-cancer care. But there was advocates that were pushing for opioids for almost many different types of pain. And as we all know, there are many different types of pain, including migraine, headaches, lower back pain, neuropathic pain, and so on. But the advocates simply embrace this as a global pain problem, and we have to engage stakeholders who have more balanced and more objective views. The FDA approval of abusable drugs, the criterion for approval needs to broaden and not be restricted to the many wonderful criteria the FDA uses for all medications. But in the case of abusable drugs, the real problem is that there are, once you have massive financial investment, massive advocacy, things, even Schedule II and Schedule III drugs that are under tight restrictions, even under those conditions, the supply can really become out of control, as it was. All the federal regulations did not spare the American public because of advocacy and huge investments in essentially advocating without accurate data or suppressing data. The unintended consequences have to be anticipated and prepared for. There was no, and there still isn't, a good approach to a transition from an individual who's being taken off opioids because the physician considers them unnecessary and being offered alternatives, or being offered treatment for a substance use disorder in case they've developed one due to their very long-term use of opioids. There is no transition here, and these unintended consequences have to be addressed. Medical education needs rapid responses to changing scenarios. At the time that I was in Washington in 2006, we surveyed all the medical schools in the country. Less than 30% offered courses in addiction and in screening patients for addiction. And by that time, by 2006, I was extremely stressed out about prescription opioids. Healthcare insurers are critical pressure points. They can make or break a lot of these issues in terms of pre-approvals, putting up barriers to treatment, to medications assistance treatment, and to approving untrammeled, unfettered prescribing of opioids. And these lessons learned are critical. We also have to alleviate stigma. And we have to be concerned that we've had many reports by the federal government, by private sector, professional organizations on how to address the problem. And the latest one is the President's Commission on Combating Opioid Addiction and the crisis. We have to create strategies for reducing all these reports to practice rather than continuing rather than continuing on the path that we have seen has caused so much disaster in the past 10 years. With wisdom, resolve, leadership, and support, I think that this problem is solvable. It's a man-made problem. The solutions reside within us. And I'd just like to close because many high-profile people in the entertainment industry, in the media, when they die of an overdose, there are headlines, there are different types of interpretations of the cause of their death, and so on. But I would like to voice a quote from Oliver Wendell Holmes: "Alas for those that never sing, but die with all the music in them. Weep for the voiceless who have known the cross without the crown of glory." It's time to weep, but also to call for action and for outcomes and for results. Thank you.
All right. Thank you so much, Dr. Madras. That was a fantastic presentation. You really threw out a lot of information and things for all of us to think about. And I'm sure we all can agree that we appreciate the work of the Commission, and we certainly hope that the recommendations that you came up with and the information you included in your report will be given fair consideration in figuring out how to move forward. And so if you unshare your screen, then I will pull mine back up and we can start doing the questions again. And we got a number of questions in, so I'm afraid we will go beyond our 3 o'clock end time, but I hope that folks will be able to stick around and enjoy the conversation that we get into now. And so our first question was something that was submitted by one of our NDEWS epidemiologists earlier in your presentation, and she was listening to the historical information you were providing, and she said, curious, it looks like in 1988, there were some folks citing that the use of narcotics was associated with abuse liability. Who were they, and why was it that they were not taken seriously, if that's in fact the case?
Well, that's a very interesting question because the problem goes much further back. In the 1960s, there were published reports that OxyContin has high abuse potential. And there was an effort, this was in the state of California, to put greater restrictions on it, and it was vetoed in California. there is, without a shadow of a doubt, I think, that every single drug that binds the mu opioid receptor has abuse liability. The abuse liability varies by its potency, by its pharmacokinetic properties, its pharmacodynamic properties, and all that. I think to point out a few naysayers, there were a number of them, and the report actually goes through the history, and if I had the time, I would delve into it. But I do cite a few of the people who were very concerned at the time that this is wrong, this is not wise, but they were swamped, literally swamped, overwhelmed by the NGOs saying that this is another manifestation of the war on drugs, by big pharma saying that this is, they're safe because extended release gets into the brain slowly. It doesn't have this rapid surge. And the model that was used at the time was the pharmacokinetic properties of cocaine, which enter the brain within 30 seconds and give you this spike of euphoria, and then it just disappears. And people felt, well, if we can create drugs that don't spike so quickly, that enter at gradually increasing doses, maybe we can avoid it. But that is not the criteria that one uses for addiction and for the consequences we've seen. The criteria is that if it's going to hit the mu opioid receptor with high concentrations, with high affinity, then you have to look way beyond pharmacokinetics in order to assess what will happen with this drug once it's unleashed on the public.
Okay, thank you very much for that information. Thank you to all of you who have submitted questions to us this afternoon. We probably won't get to every single one, but we'll get to as many as we can, and my apologies if we don't get to you. Please remember, we need you to submit your questions in writing through the Q&A box. Don't try to raise your hand. And so I'm going to move on to our next question. And this comes from somebody who noticed that you mentioned polydrug use and prescription opioids and heroin, and that many opioid users started with a less extreme drug like alcohol or marijuana. So this listener is wondering if you think there could be a link between a changing national attitude towards marijuana use and the increase in opioid use.
Well, it's a very important question because if you look at the National Survey on Drug Use data, and Beth Hahn and Dr. Robert DuPont have been instrumental in trying to excavate these along with myself. Among youth, what we see is that if young people use marijuana, they are almost 10 times more likely to use illicit drugs. If they drink, binge drink, or if they smoke, it's about the same. And most young people who use one use all three. There may be a difference in sequence. Young people may start with tobacco, move on to alcohol, and then move on to marijuana. But once those three are on board, the likelihood of them using others becomes much higher than youth who don't use at all. Therefore, from my perspective, and this is not necessarily the perspective of every commissioner, but from my perspective, preventing all substance use during youth is a critical piece of prevention. There is no question that most people who are dying of overdoses, if you look at the data, fentanyl is number one. It's currently our number one problem. It may be U47700 in another year. We don't know what is going to emerge, but cocaine is certainly emerging. And the combination of fentanyl, heroin, prescription opioids, benzodiazepines, alcohol, cocaine, and others they're seen very frequently. And therefore, what we have to do in promoting a national awareness of the opioid crisis is to promote prevention of substance use per se. As I've said in a number of presentations to people, we have become a nation of chemical coping and chemical reward. And chemical coping and chemical reward can lead to chemical addiction, which is a form of chemical slavery. We have to recognize that there are many, many roots to coping with pain, coping with psychological pain, and getting rewarding experiences in life that do not involve using drugs that alter the mind.
Okay, thank you very much for that. Our next listener asks why there is no mention in the Commission's report on the need to treat the negative health outcomes associated with the opioid crisis, specifically infectious diseases like hepatitis B and C, HIV, endocarditis, etc.
Well, it's quite interesting. Obviously, one of the problems that we have currently is that with this giant disconnect of 14,000 treatment centers from the healthcare community, it's probably one of the worst models that could be created, especially with the opioid crisis, but for other substance use, because there is no question that the use of substances causes not only addiction, which is a brain disorder, but also can give rise to physical problems such as infectious diseases, exacerbation of diabetes, sleep disorders, lower back pain. There are just a shopping list of adverse consequences that are related to one's health. And if there isn't an integration of conventional treatment with the healthcare system, we're not going to be able to address these. And I think one of the most important goals that we should have, both immediate and long term, is to develop this integrative medicine and not cut the brain off from the rest of the body in terms of how we address ailments of the brain that are not, frankly, neurological.
Okay, thank you very much. Our next viewer wants to know if the Commission discussed at all the barriers or potential barriers to prescribing buprenorphine.
Yes, we have in great depth. Anyone who wants to access the report can. It's all online. One can go into the ONDCP website or the whitehouse.gov website and look under Commission, and there you'll have full access to the report. We had a tremendous, we had sections on the barriers to buprenorphine prescribing, and there are multiple barriers. There are regional barriers, there are barriers within conventional treatment centers, there are barriers due to cost, there are barriers due to attitudes in some treatment providers, that this is simply a substitution of one opioid for another, which is in fact scientifically quite inaccurate. It is accurate in terms of opioids, but buprenorphine is a partial agonist that does not have the full-fledged effects on the opioid receptor as some of the agonists do, the full agonists. But there are barriers too with regard to the healthcare profession wanting to treat people with addictive disorders. There are, I can't remember the exact number, but there are at least 10,000 physicians who've received buprenorphine waivers to prescribe buprenorphine. I believe it's much higher than that. It may be as much as 3 times higher. But only a small fraction of those people actually use those waivers to treat people with an opioid use disorder. And that's a problem as well. So the barriers are insurance reimbursement and pre-approvals. The barriers are the costs. The barriers are the reluctance of people even trained to administer buprenorphine to administer it. There are barriers in terms of conventional treatment centers that philosophically and for other reasons simply don't want medications-assisted treatment on their premises. There are barriers in the criminal justice system because some people who test positive for this opioid may in fact be penalized for it by a judge. There are so many barriers. We talk a great deal about these barriers to medications-assisted treatment.
Okay, thank you very much. So I've also noticed a number of people submitted questions asking about your slides. They were excited about some of the things you included and were wanting copies of things. So I just want to let everyone know that we will put a copy of the slides on the website, www.ndews.org, after this webinar is complete, as we have in the past. So you will be able to see copies there. And if you have any specific requests about particular slides that you might like to try to incorporate in a presentation of your own, or if you want to extend an invitation to Dr. Madras to participate in something you're putting together locally, I would encourage you to get in touch with her directly to work that out. And so I also have noticed a number of questions coming in from people who kind of want to know, where do we go from here? What happens next? What can we do as a community to encourage the administration to pay attention to the good work that's been done by the commission and the recommendations that you have made, and start to actually move and take action to implement some of the recommendations and to provide funding to move forward on some of these things?
Well, I was disheartened to see in a poll of what things most Americans are concerned about, that the opioid crisis, in a recent poll that I saw, and I would love to be able to cite it, but I don't have the citation in front of me, that most Americans did not even mention the opioid crisis as uppermost in their mind. They were far more concerned about other issues currently. And my feeling is, unless there is, there has to be a groundswell of support for the commission. The administration is dedicated and very committed to acting on the commission. There has been a lot of movement within the executive branch of the government, at the level of Health and Human Services, in the VA system, at the level of the White House. Most definitely, Kellyanne Conway has been assigned to coordinate all these various agencies in terms of response. But I think, and the federal government is looking at every single one of these daunting set of recommendations to try to understand which ones they can act at, how the implementation hurdles. And I will say without a question, without a shadow of a doubt, that any solution that anyone can think of that is so obvious: educate medical students and doctors, refer to the PDMP files, distribute more naloxone, increase medications assistance treatment, and so on. Every single one of these I looked at in great depth and found the obstacles and barriers to implementation are really the heart of the problem, and also the legal issues. For example, and I'll give you 2 examples. One example is educate doctors on proper prescribing. Mandate that they have to take a course on opioid prescribing in order for them to be re-registered annually by the Drug Enforcement Agency. Now, the Accreditation Council for Continuing Medical Education has educated about 200,000 people who are licensed to prescribe opioids. Of those, 60% change their practices. Now, of the rest, some may not need to because they're fine, they're prescribing according to guidelines, but many others are not changing their practices. What do we do next? It's a simple solution: educate. Does that mean that people are going to change? Does that mean that a physician who has patients who he is concerned about because he perhaps in the past he's overprescribed, what will he do about it? Will he reduce the prescriptions? And if he does, what happens to that patient if they have, in fact, in the course of their pain, become addicted? What does he do next? Who does he call? What does he do? So many of these recommendations require multiple layers of detail in terms of solutions. And you know, I gave you the example of of buprenorphine. What are the barriers to buprenorphine? There are multiple barriers elsewhere. So essentially, the executive branch now is going through these recommendations with the appropriate, with the Office of National Drug Control Policy, with the FDA, with CMS, with SAMHSA, with the CDC, and trying to understand how federal intervention, including the costs involved, can fulfill the spirit and the implementation of these recommendations. But I assure you, nothing is simply let's do this or let's do that. And I would love to see a switch turned on that just closes off this crisis, closes off the overdose deaths. But it's going to happen, but it will take some time. And grassroots people can have an enormous influence. From the level of a family, they can educate their children on the harms associated with drugs. And they can begin at that level. From the level of college administrators who are very permissive in terms of substance use on campuses, they can begin a program to educate their students on this problem. High schools can. Certain state governors that I'm familiar with, and I'm sure there are many others, Governor Charlie Baker in Massachusetts has done a spectacular job of developing strategies for the state of Massachusetts. And this year, during 2017, for three quarters of the year, there's been a 10% drop in overdose deaths. This is the first glimmer of hope. It may not persist. It may spike again. We don't know. But so far, what he's doing is certainly not harmful, and it appears to be very helpful. Every level, every sector, every scientist, every physician, every parent, every teacher should be involved in this, in education, because it is really a national and it is a community and a local problem. CATCA, the Community Anti-Drug Coalitions, are very committed in terms of their community responses. That's one sector that's working, but there are many others that have to be involved.
All right, thank you for all of that. I think that actually addressed a number of the questions we had coming in, because there were a number of people who were submitting suggestions for other kinds of recommendations that the commission could consider related to pain being considered a vital sign, for instance, and that probably not being a good way to go, and the prescribing of opioids and how to train physicians and educate students in schools and that kind of thing. And so along those lines, one of our listeners wrote in about SBIRT and RSDT and wants to know what it will take to implement SBIRT or RSDT universally rather than to selected groups?
Much for that question, because it's almost as if it was a planted question, but it certainly isn't. For those of you who may be aware, SBIRT was one of my zealous programs that I promoted with great zeal when I served in ONDCP, in the White House Office of National Drug Control Policy, about a decade ago. I felt, and I would love to just take 1 minute as an anecdote. The first meeting I scheduled when I assumed office as deputy director was to go to the headquarters of the American Medical Association. And I went there because what you learn in government is you don't go anywhere to chat. You go to people to ask them for something that they can help you with. I went to the headquarters of the AMA asking the AMA to help me with SBIRT. At that time, it had lain foul, just gathered dust in scientific manuscripts. The federal government had invested some millions of dollars, about $12 million, in trying to get states to implement SBIRT. But I knew that there was no uptake of this screening, brief intervention, referral to treatment program. And I excavated the data as I did for this report. What are the points of resistance to change? What are the obstacles to implementing things that can be implemented, that should be implemented? And one of the ones was that physicians don't have time. There's no reimbursement for screening patients for addiction. And there's no time because in a 15-minute interview, they have to evaluate and manage a whole host of other potential medical problems. And so when I spoke to the head of the American Medical Association, the executive director, Dr. Michael Maves, I said, I need your help with SBIRT. I would like to get billing codes for it. And he was, at the beginning, skeptical and puzzled because, for a number of reasons. And I said, here's my reason for it. It is because of prescription opioids are being prescribed by physicians, and we are seeing an increase in addiction and overdose deaths due to drugs that are being prescribed by physicians. At that point, he was riveted and attentive. He invited me to the CPT board to present a petition to enable billables, billing codes, so that physicians could set aside the time. And after a number of obstacles that we overcame, tremendous obstacles, because the board initially said, why should we bother with addiction? What about alcohol? What about jogaholics, computerholics, shopaholics, chocolateholics? Where does it end for physicians? Where do we stop worrying about all of the behavioral problems that people have when we're trying to deal with infectious diseases, with cancer, and so on? And the response to that was that of all these things you've mentioned, addiction is not only a brain disease, but it could give rise to very serious medical diseases. And we got the billing codes. And it turned out that these billing codes did reimburse, but there still wasn't the time, and there wasn't sufficient reimbursement to take into account the amount of time. Now, since then, there are electronic versions of the questionnaire. There are many things that have been done to move it forward. But from my perspective, the biggest gap in promulgating SBIRT in every hospital, in every healthcare system, in every school system is what to do if you get a positive. Where do you refer a patient? What do you do about it? And how can you ensure high quality? Which at this point in 2018 in the United States, the quality issue to me looms larger than ever. There's some wonderful treatment centers in the country, but they are the minority, and we have to improve treatment.
Okay, thank you for that. I'm going to take a break now from the questions and launch our poll because I want to catch our participants before they exit our meeting and just get some information from you about how you felt about this webinar and what topics you think we should focus on moving forward. So I'm going to launch the poll now, and I'd appreciate it if you would take a few moments to answer the questions for us as we continue to move through your questions with Dr. Madras. So one question that I want to ask you on behalf of NDEWS and the work we're doing is what developments in the field of epidemiology would you like to see going forward?
There are a number of issues I think that we still don't have a good handle on. For example, what types of pain patients are most likely to progress to self-increasing doses and or addiction? I don't think we have good numbers on that. Is there a type of pain that gives rise to dose escalation and to addiction? There's so many questions like that. That's one of them. In terms of epidemiology, I'd like to know how many people currently are becoming addicted to prescription opioids due to diversion as opposed to legitimate medications. In other words, how many unintended people are becoming addicted currently? Is the downturn in prescribing practices reducing that number differently than patients themselves? Or is that balance between the two, are they still the same as they may have been 10 years ago? The other big data analytics that I think is critical is whether or not, for example, what in terms of naloxone, we don't, state by state, we do not have cohesive records keeping on the gender, the age, the racial and ethnicity, the location, the types of drugs that were in the system on a national basis. Some states do spectacular jobs of gathering that information, other states less so. New Hampshire, Massachusetts, New Jersey, they're doing extremely well. Some of the others have really voids in the data on not only naloxone rescues, but also on overdose deaths. I would love to see what are the obstacles to developing national testing for all these drugs. Some states don't even include alcohol if they think it's a fentanyl issue. We have to have uniform data on so many issues. There are many other epidemiological issues that I think could be expanded. These are some that just come off the top of my head, and I have a list of them that I've kept a running list in the course of composing the report, which I can share with that questioner once I access my other computer.
Thank you very much, Dr. Madras. And thank you again to all of you who participated in our webinar this afternoon. We really appreciate all of the questions that you submitted. I think the length of this discussion and the breadth of the topics that you have introduced and brought up, and the intelligence and the concern and the passion with which you are bringing them up just demonstrates how much we all have to do to address what's going on in the United States, and how much we all need to work together and find new ways to do that and better ways to do that moving forward. So I apologize again that we didn't get to all of your questions and all of the topics that you wish to discuss, but we will follow up with Dr. Madras after this webinar, and we will work with her to provide some additional information on our website at www.ndews.org. And again, we will also post a full recording of this webinar and a copy of the slides there as well. And so I hope that for those of you who are still with us, we will see you at our next NDEWS Presents webinar, which will be on February 28th at 2 p.m. Eastern. And we will be joined again then by Jill Head, Supervisory Chemist at the U.S. Drug Enforcement Administration, and she will be presenting on synthetic drug trends in the United States and updating us, as she does every year, on what new substances and different substances they are starting to see in the specimens that they're testing in their lab. So again, thank you very much for joining us today, and we look forward to seeing you again. And I don't know, Dr. Madras, if you had any closing comments before we go?
I just want to thank everyone who was persisted for the duration of this presentation, and by even being on it showed a commitment to trying to solve this problem. So I thank every one of you for listening, and hopefully I can interact with you in greater depth when the occasion arises. And just remember, the lessons learned, they apply today to other drugs, including marijuana, including cocaine, including hallucinogens, and other types of psychoactive substances.
All right, thank you very much, and we'll see everyone again at our next webinar in February. Have a good day.
Thank you.